So good morning and welcome to Module 13. So we're up to 13 modules out of 16 already. And what we're going to be talking about today is the nutritional management of common cardiovascular conditions. So back in the 1950s and 60s, when Dr. Goodhart started developing applied kinesiology, he talks a lot about phonocardiography from Royal Lee's work back with standard process in the 1940s. And this was a device which measured the heartbeat on a piece of wax paper and showed the different heart sounds and the gaps between the heart sounds and the heights of the heart sounds. And they were able to use a lot of that work to diagnose particular deficiencies, particularly in different types of vitamin Bs, which we're going to talk about, because they have different functions within the cardiovascular system. Then by 1970s and 80s, there were early analog type machines which had been developed to actually do these recordings that you could see on a machine with a little screen. And then by the 1990s and 2000s, certain companies had done digital stethoscopes, stereo stethoscopes, which you can wire into a computer program, which is what I'll demonstrate. So the modern phonocardiograph is a specialized stethoscope which just listens to the heart, records the beat, and puts it out on an audio-visual program there. So a phono obviously means listening, and cardiogram means listening to the heart, is a recording of the sounds and murmurs made by the heart with the help of a digital stethoscope, of the sounds made by the heart during the cardiac cycle. In other words, between the lub, dub, and the next lub. So that's called a cardiac cycle, as we learn. The sounds are a result from the vibrations created by the closure of the different heart valves. And we'll see the heart valves close in pairs. There are at least two. The first, when the atrioventricular valves close at the beginning of systole, that's the lub. So between the atrium and the ventricle, on both sides, on the left and the right, are the big tricuspid and bicuspid valves. And when they shut, they give the first heart sound, which is the big one, the lub. And then the second is when the aortic and the pulmonary valves, which are from the ventricles, pumping the blood out into the main arteries to the lungs and the body, when they shut at the end of the systole. So it allows the detection of sub-audible sounds and murmurs and makes a permanent record of these events. So you can record heart sounds which you can't hear with a stethoscope, an ordinary stethoscope, but you can see it on a graph very, very well. So this is interesting statistics. 80% of all physicians die of heart disease, which is interesting from our point of view today, because a lot of these conditions are due to deficiencies or imbalances, functional problems. So 80% of cardiac conditions are muscular. That means the big, strong muscles of the heart, which we're not going to go into detail today because we've done courses previously on phonocardiography. But the left ventricle, which is the bigger of the two ventricles, the width of the heart muscle in the ventricle is the width of your thumb. So you can see that's a powerful bit of meat really in there. And when that gets tired, of course, we have problems being able to pump the blood round, and therefore to get the oxygen round. So when we've got a muscular problem, we get a poor heart contraction, and this leads ultimately to hypoxia. And hypoxia itself, of course, leads to low oxygen delivered to the tissues, particularly the muscle tissues. So again, we get a poor heart contraction. So magnesium, which helps us to build up the hypoxia, build up the contractions of the muscles and building up the oxygen in the blood, is very, very important here. So of the remaining 20%, 10% are probably valvular problems. And the valves are mainly made of collagen type of tissue. So we have learned about collagen, and we know the importance of the different substances that make collagen. 6% are nervous, meaning that they be associated with fibrillations and irregular heartbeats, etc. And these, as we see, are electrical conduction problems, usually due to a deficiency of vitamin B1. And 4% are coronary, which would be largely called coronary occlusion, which will lead, as we'll see, to angina, or ultimately perhaps to a clot or an embolism known as a myocardial infarct. And more people are affected and die with heart disease than any other illness. Although probably in some areas cancer is catching up fast, primarily because heart conditions are being managed better, whereas perhaps not so well managed with cancer conditions. But still, it's the number one affliction and killer. Now, from a functional point of view, we're lucky in applied kinesiology because Dr. Goodhart found the relationship between the meridians, the nervous system, the vertebral levels, and the muscles and the organs. And in some cases, we have 5, 6, 7, 8, 9, 10 different muscles associated with one particular organ or meridian. But with the heart, we have just one, which is the subscapularis muscle, which is directly associated with the heart. So let's have a look at the subscapularis. So it's in the anterior part of the scapula, so it's a part where we can't actually feel the muscle directly in there. And we'll see that the upper fibers here are horizontal. See around there, and then the lower fibers here are more oblique. So this means that we have basically two testing positions. So one of the testing positions will be this way to bring internal rotation. We'll do the upper fibers, the more horizontal ones, and then the more standard one here is really testing the more oblique muscles here. So we have two testing positions, this one and this one. And those two testing positions, maybe on each side, may also pick up whether it's the left side of the heart or the right side that's involved. We don't know that for sure, and it'd be nice to think that maybe the different positions picked up the different valves, but again, we don't know that. So it's inserted to the lesser tuberosity of the humerus and the fibrous capsule. Now, because it inserts into the fibrous capsule, it makes it part of the rotator cuff. So the four muscles of the rotator cuff are muscles which connect into and insert into the fibrous capsule to give the fibrous capsule extra support, because it's a fairly loose ball and socket joint, the shoulder joint here, and it only has a few ligaments to support it. So it's basically a medial rotator of the humerus, in other words the shoulder joint, the humeral joint. It's supplied by the upper and lower subscapular nerves, which is the lower part of the cervicals, 5 and 6, and the associated meridian and organ is the heart. So basically the heart pumps the blood, and the blood carries the oxygen and the nutrients around the body. So when we come up with a heart meridian, it's not necessarily the heart, the organ itself, it's what the organ does physiologically. The same with all meridians. It's not necessarily a pathology of the organ, it's what the organ does from a physiological point of view. So if I can get somebody up and we'll do a demonstration of the heart muscle, and then we'll carry on. So just cut there. Okay, so right, we bring the elbow to the side, slight medial rotation here, hand nice and flat, and you push the hand towards your tummy button. Good. And then 90 degrees of shoulder joint and elbow. Slight medial rotation, let it drop down a bit more. That's it. Hand flat and push down towards the floor. And then we'll do the same on this side. Okay, and push the hand in. That's it. And down. Let me just rotate it a bit. That's it. And hand towards the floor. So we have a weakness on the left subscapularis here. Okay, so in a minute we'll find out what's the cause of that. Okay, thank you. That's it. So the aortic area, the pulmonary area, tricuspid and mitral area, these are the valves of the heart, are the areas of the surface of the chest where the heart is auscultated. So in other words, to listen to the heart on the surface. Heart sounds result from the reverberation within the blood associated with the sudden blocking of flow reversal by the valves closing. So we get this noise come out because the valves snap shut during contraction of the heart. Because of this, auscultation to determine the function of a valve is usually not performed at the position of the valve, but at the position where the sound is heard best or reverberates. Okay? So the position where we put the stethoscope is usually slightly away from the actual anatomical position. So here's the actual anatomical position with the heart superimposed in there, mitral, pulmonary, aortic and tricuspid. And here's the position where we optimally listen to the heart. So you can see it's a little bit further out over there with the aorta over here, pulmonary, tricuspid, mitral. And then the E point, which is the Ebbs point, we'll see is really where we put the stethoscope on to listen to all of them at the best. So this Ebbs point here is the left third intercostal space. So that'll be down here. So just by the sternum, just lateral to the sternum in the third space there, is the best position to listen and also to record the heart sounds. In cardiography, Ebbs point refers to the third intercostal space on the left border where the second heart sound is best auscultated. So S1 and S2 refer to the first sound and the second sound respectively. So when we say S1, it means the first sound, the lub, and S2 is the dub. It is essentially the same position as what is referred to with the lower sternal border. So what we're listening to is the heart. As we can see here, it's basically a muscle, and it contracts and sends blood through the pulmonary and the aortic. So we've got different blood supply. The first blood supply off the aorta, when the new blood, the oxidized blood comes out, goes to the heart muscle itself, and these are called the coronary muscles, the coronary arteries. So we've got number 1 there is the right one, and then we've got the 2 is the left descending one, and then we've got the left circumflex one here, which goes round, and then you've got the big ones, the superior and inferior vena cava, which are bringing venous blood into the right side, the aorta, which is pumping the blood out, and then the pulmonary artery, number 7 here, which pumps it out to the arteries, to the lungs to get oxidized, and the pulmonary vein, number 8, which brings it back in. So normal heart sounds, lub-dub, 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 lub-dub. So S1 is the first sound, the lub, and S2 is the dub. So we have lub-dub, lub-dub. And the difference between the S1s to the next S1 is called the cardiac cycle. And this, as you know, is roughly 72 beats per minute. So we're looking at 1.1 beats per second. Okay. Now you'll notice that we have a lub, which is when the mitral and tricuspid valves shut, and the dub, which is when the aortic and pulmonary valves shut. That's the period of the contraction of the heart itself, of the ventricle of the heart. This is therefore the working period of the heart. So when the heart contracts, it's working, it's muscle contracting, and then between that and the next beat is the resting period. So you have lub-dub, rest, lub-dub, rest, lub-dub, rest. So now you see that what should happen is the distance between lub-dub and the resting period here, this is half the distance of this, or the resting period should be ideally twice as long as the working period to give the heart a chance to recover and get the blood and the oxygen into the heart itself there. So if this distance is shorter, it probably means there's not enough oxygen and nutrients getting to the heart itself, because it's not relaxing long enough for the blood to flow back into the heart itself. So it should be lub-dub, lub-dub, lub-dub. So we can roughly put this also into an electrocardiograph. We're not experts in electrocardiograph, and I don't want to spend time particularly talking about that. Whereas with the phonocardiograph is something which is very easy to do. We can listen to the heart with the stethoscope, with a standard 8-pound stethoscope. There's no problem to listening to somebody's heart with it and putting it on there. But what is really interesting is that the subscapularis muscle, which Dr. Goodhart found some 50 years ago associated with the heart, is the muscle that goes weak when there's a cardiac problem. Okay? And that if you feed the heart sound back, which most of us don't ever hear our heart sounds, if you feed that back with the patient with the stethoscope on, that's when the subscapularis goes weak with most people, because very, very few people have a perfect heartbeat. Okay? You think you do, and the pulse is nice and regular there, but very few people have a real lub-dub, lub-dub, lub-dub. And especially when you're belting off down the track. So if you're an athlete and you're going for a run and things, you still need your lub-dub, 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 but all speeded up. Okay, but you still need your resting periods, obviously, for the heart to function aerobically. So we find that the feedback, biofeedback using a stethoscope, is very impressive to sports people. But generally, in the clear as such, in other words, with no other added bits and pieces, challenges, the feedback is only to the subscapularis muscle. Okay, in normally, so getting to know how to test the subscapularis muscle is very, very, very important. So the first sound is 2 to 3 times louder than the second sound. So lub dub, lub dub, lub dub, lub dub. Okay, that's the important thing, because the sound of the mitral and bicuspid valves shutting is the important thing there. Is the contraction of the ventricle itself, the power of the ventricle. So it should be louder. So the first thing is it should be higher, therefore, on the cardiograph. So if we go back here, you'll see this is much higher amplitude with the wave than the S2. Okay, so this should be 2 to 3 times the size. And that really is on the phonocardiograph. That's the most common problem. And I don't want to go into the technical details of all the different functional problems. But very frequently, this is very soft in comparison to what it should be, which means the heart isn't contracting enough. And the most common reason for this is hypoxia, in other words, lack of oxygen getting to the actual muscles of the heart itself. Sometimes it's round the other way. The second sound is higher, which means we're getting pressure back from the arteries, from the pulmonary and the aorta, back to the valve. So when the ventricles contract and we send the blood into the aorta, and then the valve shuts. If it shuts loudly, it means we've got high blood pressure. So we've got hypertension. So you can tell all sorts of things. And I would refer you, if you're interested, we've done several modules on phonocardiography, and it's very easy to carry out, which are all recorded with us from previous seminars. The period between the second sound and the next first sound should be twice as long as the first period. Okay, so again, lub dub, lub dub. In other words, twice the height for the first sound, but twice the distance between the dub and the next lub. Okay, that's the important. In other words, that resting period. This is normal. Anything different is abnormal. Now, when we've done hundreds of recordings over the years, we haven't found a normal one. It's about as normal, commonly to be normal, as a normal occlusion. If you go to the dentist, they'll always write something about your occlusion. However good your teeth are, and however good your bite is, and the temporomandibular joint, there'll always be something with your occlusion, and there's always something with the heart. So you always find, and we haven't yet found anybody, when you put a stethoscope on them, who doesn't weaken to the subscapularis. Usually on one side, and it's more commonly, it's the oblique fibers, more commonly than the horizontal ones. But anything that strengthens that challenge is good for the heart, because you were talking directly to the heart. Now, because you don't normally ever hear your heart, but sometimes we have a loud sound on the lub-dub, and then we hear our own heart. And people sometimes, when they lie down, they hear their heart beating when they go to bed. I had one patient the other week who said, I thought I died during the night. He said, because I didn't hear my heart sound. And I said, well, it's not normal to hear your heart. Oh, isn't it? So he was so used to hearing his heart that he thought he'd actually died because he didn't hear it. So both auricular ventricle valves must close at the same time. Now that closure is the first heart sound. So in other words, on the left side and the right side, the valves between the atrium and the ventricles must close at the heart at the same time. Otherwise you get a split first sound, which you pick up, of course, on the cardiograph very easily, because you've got two first beats very close together, but they're separate. So that means they're not shutting at the same time. That's an electrical fault. So in other words, the electricity which is making the heart beat from the different AV nodes and things is not synchronous. Pulmonary and aortic valves are closed by the blood pressure pushing back, thus creating the second heart sound. That's the dub, okay? So if we've got high blood pressure, then we get a higher sound. And if we've got a split second sound, then again we've got an electrical problem. So the rest period is longer, as this is the period when the ventricles are opening again and should be twice as long as the closing period so that it can reoxygenate and refeed. So that's basically what we'll have a look at a bit later on. So you can do this with a simple, very cheap stethoscope. You can listen to your own heart if you're a little bit of a hypochondriac. But the fascinating thing is that you only weaken to the sound of your own heartbeat. If you listen to somebody else's heartbeat, even if it's irregular, you won't weaken to it. Somehow you recognize, your brain recognizes your own heartbeat, because the heart is mediated by the vagus nerve, and the vagus nerve is parasympathetic. And we have two vagus nerves. We have a vagus nerve on the right and a vagus nerve on the left from the foramen whatever it is. Back to me in a minute. So the left vagus nerve operates the heart, operates the beats of the heart. It's like the brake on the heart. So the speed of the heart itself is on the left side. The amplitude of the heartbeat comes from the right one. So if we have a lesion in the occipital mastoid suture there at all, what we find is we've got pressure on the vagus nerve on the right, will change the size of the beat, and if it's on the left, it changes the rhythm. Okay? So the vagus nerve is actually 90% sensory. So 90% of the function of the vagus is actually sending information back to the brain stem, about the heart and about the organs that it innervates. In other words, the intestines, the liver, the lungs, etc. So there's a constant feedback from the organs to the brain, as well as the parasympathetic supply from the motor point of view. Okay? So this is why you will weaken if there's an abnormality to yourself, but you won't weaken somebody else, because your brain won't recognize that that's you. Okay, so even if you've never heard your own heart, you'll still generally, we found 100% of people will weaken to the subscapularis, because nobody has a perfect heart, much as we'd all like it. So we'll run a cardiograph and demonstrate this just a little bit later. We'll set it up and then we'll demonstrate it on somebody. Okay, so now let's talk about, before we actually get into sort of functional problems, I put this at the beginning because this is something new that we've developed over the period of time since we ran the phonocardiography courses, is predisposing factors, as we'll see, towards cardiac problems. And one of these is trimethylamine, which is probably a substance you've never heard of before. You've got a vial of it to test. So trimethylamine is an organic compound. This colourless, hygroscopic and flammable tertiary amine has a strong fishy odour in low concentrations and an ammonia-like odour at high concentrations. In humans, it's synthesized exclusively by gut microbiota from dietary nutrients such as choline and carnitine. High levels of trimethylamine are associated with the development of fish odour syndrome, which arises from the foul fishy odour of trimethylamine. So if you smell rotting fish, that's trimethylamine, and if you smell that on the breath of a person, you know that they have this problem. Now, it may be at a low level, and if it's at a high level, it may have an ammonia type of smell. It is the substance mainly responsible for the odour associated with rotting fish, some infections, bad breath, and can be the cause of vaginal odour due to bacterial vaginosis. It is, when it's in the urine, is an autosomal recessive genetic disorder involving a defect in the function of expression of flavin-containing monooxygenase 3, otherwise known as trimethylamine monooxygenase, which results in poor trimethylamine metabolism. Individuals with trimethylamine develop a characteristic fishy smell, as we said, in their sweat, their urine and their breath after the consumption of choline-rich foods. Okay, so what are choline-rich foods? Liver, eggs, wheat germ, soybean, scallop, salmon, and chicken. And of course, anything that involves also high concentrations of choline, which could be phosphatidylcholine or lecithin derivatives. Okay, so these people may have this problem in not being able to metabolize trimethylamine correctly, ideally. So here we see choline, carnitine, and other compounds in that same family. Betaine is another one there. Going through the enzyme here, choline trimethylamine lyase to the gut, creating trimethylamine, which will then break down by this trimethylamine dehydrogenase enzyme, which needs B2 to metabolize it. So a deficiency of B2 may lead to a buildup of trimethylamine, and this would normally be broken down to formaldehydes. Now, this whole process with the flavin monooxidase here may be modulated by resveratrol, which we get from the skins of red grapes and peanuts and things. His resveratrol attenuates trimethylamine oxide-induced atherosclerosis by regulating trimethylamine oxidase synthesis and bile acid metabolism by remodeling of the gut microbiota. So the important thing of this, and as we briefly talked about the vagus and things, is there's a direct connection between the gut, the microbiota, and heart problems. Okay? Now this has become established over the last 20 years. So we also know that there is an association with these things also involved with the teeth or the gums. So the gum disease links. So orthodontics, periodontists are now working much more with cardiologists, and gastroenterologists are looking at cardiology, and cardiologists are thinking maybe cardiac problems are not the heart itself, but are being influenced by chemical changes in the gut, and maybe even bacterial infections, etc., in the mouth. So trimethylamine oxide is a product of the oxidation of trimethylamine. A study published in 2013 assessing 513 adults with a history of major adverse cardiovascular events. Seem to be running out of battery for some reason. An average age of 68 and 69% of whom previously or currently smoke may indicate that the high levels of trimethylamine oxidase in the blood are associated with an increased risk of additional cardiovascular events. The concentration of trimethylamine oxidase in the blood increases after consuming foods containing carnitine or lecithin, as we said, choline, if the bacteria that convert these substances to the oxide are present in the gut. High concentrations of carnitine are found in red meat, some energy drinks, and some dietary supplements. Lecithin is found in soya, eggs, an ingredient in many processed foods as a dietary supplement. Some types of normal gut bacteria, the Actinobacter in the human microbiome, convert the dietary carnitine into trimethylamine oxidase. So Actinobacter are the main bacteria which do this conversion. So if we got a dysbiosis and we had an excess of that, and you've got the defect in the enzyme, and then you may end up with high levels of trimethylamine. So trimethylamine oxide alters cholesterol metabolism in the intestines, in the liver, and in the artery walls. In the presence of trimethylamine oxidase, there is increased deposition of cholesterol in and decreased removal of cholesterol from the peripheral cells, such as those in the artery walls. It has been suggested that it may be involved in the regulation of arterial blood pressure and the etiology of hypertension and thrombosis, in other words, blood clots, which we'll look at later, in atherosclerotic individuals. 2010 meta-analysis found higher concentrations were associated with a 23% higher risk of cardiovascular events and a 55% increased risk of mortality. So could red wine and peanuts prevent a lot of these events with memory loss and cardiovascular? The indication is perhaps they could. Cardiovascular disease primary prevention clinical studies. So we'll go through that. So probably most of you are familiar with the fact the major artery coming out of the heart, out of the left ventricle, is the aorta. And the aorta curves round and goes down into the abdomen, and then will eventually end up as the femoral arteries down the leg and down into the feet, and the brachial arteries in the arms going down to the hands and the fingers there. In the head, when it goes up, it's called the carotid arteries, which then go up into the circle of Willis, into the head, etc. And on here, the blue vessels are the veins bringing deoxygenated blood back through the jugular veins from the head here. The brachial veins, superior vena cava is the major one here, and the iliac veins bringing blood up from the legs there. So how do we test hearts and heart function? We can do urine tests, we can do blood tests, electrocardiographs, but for us probably the easiest is the phonocardiograph directly. In other words, we don't have to necessarily do the full works with the recording, but you can simply do it by the biofeedback using a stethoscope and listening to the heart, or you listen first of all to the patient's heart, then you put it over that Erb's point and then muscle test them with the subscapularis. So let's have a look at a few of the common problems. Now remember what I said, cardiac problems, like all sorts of problems, but particularly when we talk about cardiac problems, sound pretty drastic. High blood pressure, cholesterol, arteriosclerosis and things. What we have to remember, these are results of abnormal physiology which lead to dysfunction and ultimately to pathology. Okay? So it's what is the cause of that which is the most important thing. And the same rules apply. Is it due to something toxic? Have we got a build-up of adverse substances from outside the body or from metabolic intermediate substances created inside the body? Or are we deficient in some essential nutrients? Or is it a combination of the two, which is usually the most common thing? So let's have a look first of all on blood pressure and heart rate. So the flow of our blood is the difference in the pressure against the resistance. So think of the heart when it contracts as you turning the garden tap on with the hose. So when you turn it on and off, once every 1.1 seconds, you get a spurt at the other end, right? And then you get a trickle because there's still water in the tube in the hose pipe. Okay? It doesn't go spurt, stop, spurt, start. It goes spurt and then a dribble or a trickle at the end there. So the spurt is systole when the heart contracts, and when the heart is relaxed it's called diastole, in other words the resting period of the heart. So just imagine turning the tap on, off, etc. It's exactly the same with the heart. So the pressure depends upon the resistance of the hose pipe. Okay, so in other words, the tougher the hose pipe, the less elasticity there is in the hose pipe, the pressure will be much greater. And that's the same with the blood pressure. So if the arteries are stiffening, you get a higher blood pressure. Okay. So here we see a more detailed picture of the heart with the right atrium here and the right ventricle. That's from the blood coming in from the veins. And then we see the left ventricle here, which is the main input from the pulmonary vein bringing the blood in from the oxygen from the lungs there, and then spurting it out through the aortic valve here with the aorta, and then you'll see the different channels coming off, going up to the head, and behind there are the coronary vessels. So this is the left ventricle here, which I was talking about, and this on most people is about the width of the thumb of the person. Okay, so there's a lot of muscle tissue in there. A lot of medications are prescribed. It almost seems that every other person over the age of 60, maybe 50, has some form of cardiac medication, whether it's a statin drug to regulate cholesterol, or whether it's a blood pressure medication, or a beta blocker to steady the heart rate. They all seem to be on the same thing, or an aspirin to thin the blood. And we'll see that there's natural medicine equivalent. So diuretics, vasodilators, angiotensin inhibitors, antagonists, beta blockers, calcium channel blockers, nervous system inhibitors. There's a whole range of medications, pharmaceutical, that many patients are on. But really none of them address the cause because none of them cure the problem. You know, some patients find that their blood pressure is restored to normal, but of course mostly when they come off the medication it goes back up because it hasn't addressed the cause. But the cause is more fundamental, and if we can get to the cause then hopefully the person wouldn't need to get on blood pressure medications, or could hopefully come off them over a period of time. Now, we know that the blood vessels themselves are mostly regulated by adrenergic receptors, which means by noradrenaline and adrenaline. So these are some of the major modulators of blood pressure through adrenaline. But in fact, all neurotransmitters have an effect on the arteries and the arterioles, directly or indirectly. So let's have a look at the individual ones. We know that neurotransmitters, when they're deficient effectively to the actual cell that they're targeting, correspond to the yang meridians. So each of the neurotransmitters has a yang meridian point. We've done this in the neurotransmitter module. And when the neurotransmitter is in excess, it registers as a yin point on the body. So all the yin points are the excesses or high levels of the neurotransmitter, and the yang points are the low levels. So let's go through them very quickly one by one, because each of them has an effect on blood pressure. And that means that if we could diagnose or have a marker that a person's got hypertension in some way, which I've seen done with just pumping up a sphygmomanometer cuff and holding it there on the arm or on the leg, or there are some therapeutic points that some practitioners use to register that the person's got hypertension, and then cross-check that challenge to the different beginning and ending points on the face and the trunk. So let's have a look at acetylcholine, which we're familiar with. Acetylcholine here, deficiency here, is made from choline and the acetyl-CoA, which comes from pyruvate here. And then we got here, to do this conversion, we need B1, B2, B3, B5. And this is an interesting pathway. The adding of the acetyl-CoA from the energy pathway there to the choline there is done by choline acetyltransferase enzyme. Choline acetyltransferase means it transfers the choline and the acetyl group together there. Now, this is inhibited, as we've talked in previous ones, by atropine, which is used to help people study when we want to dilate the pupils, ethanol, cadmium and mercury. So these things would actually decrease the effect of the parasympathetic nervous system through what's called the muscarinic receptors. All these pathways and their cofactors are validated in Brenda's enzyme database, which you can obtain just by going to brenda-enzymes.org. One of the most fascinating ones I found, which I found really clinically significant here, is iodine. And iodine is a cofactor for this choline acetyltransfer enzyme. And this is interesting because many people do say if they take iodine as a supplement that they feel so much better with their memory. And iodine actually may be very much involved with spatial awareness in young children, in infants, and some infant formulas we notice are now containing iodine to optimize brain function. And the reason for this is it helps to optimize the cholinergic neurons, which are involved with the learning process and memory recall. So iodine plays very important parts, as we know, in the thyroid hormones, in the balancing the estrogens. It's an antiseptic, so it's involved with the immune system. And that's a fourth function that we know now of iodine. And therefore iodine deficiency may lead ultimately to low acetylcholine. So it could affect our memory, it could affect our neuromuscular strength there. We break acetylcholine down, and by acetylcholinesterase, which is a B2, B3, and a manganese-dependent enzyme there. And we'll see that breaking down of acetylcholine can be inhibited by a lot of pesticides, solanine foods, which we're going to talk about in the next module. Sodium fluoride, which of course is a toxin, to acetylcholine breakdown, etc., which you can read all those. Okay, so low acetylcholine registers off the gallbladder meridian here on the side of the face, and the acetylcholine is like the brake. Parasympathetic nervous system, if you like, regulates the whole of the body function, so it acts as a brake in comparison to adrenaline or noradrenaline. So it doesn't necessarily slow us down, although sometimes it does, but it regulates it. It keeps it on a nice balance every day, sort of things. So if we have low acetylcholine, we'll then get a high heart rate. Okay, so it's like lack of the brake, if you like, on the car, leads to high heart rate or tachycardia. So that would be one of the conditions that the person may have, is they've got a fast heart rate. It may be irregular, but it could be fast. And you pick that up with the stethoscope, and then you can feed that back with the stethoscope to the different meridians, and if it cross-checks to the gallbladder, you think, they've got low acetylcholine. High conduction rates, which leads to the tachycardia, high atrial contractions, high ventricular contractions, and therefore high blood pressure. Okay? So in other words, a lack of the brake will lead to high blood pressure. That's how it does it. Okay? So that's low acetylcholine. High acetylcholine will slow the heart rate because we've got too much of the brake, so we get bradycardia. So tachycardia is a fast heart, bradycardia is a slow heart. We get slow conduction rates, slow atrial contractions, slow ventricular contractions. Therefore, you get low blood pressure. So a high acetylcholine will lead to low blood pressure, and it stimulates the release of nitric oxide, NO is nitric oxide, in the blood vessels, and so vasodilates. So the major dilator of endothelial blood vessel tissues is nitric oxide. So high nitric oxide will lead to vasodilation, and we'll see other neurotransmitters also work by stimulating or inhibiting nitric oxide. It's possibly the mechanism how a number of drugs work. So we here see acetylcholine and working through the endothelial cell in the small blood vessel walls, where we have arginine, the amino acid. In the presence of nitric oxide synthase, will produce nitric oxide, and the byproduct will be citrulline. So nitric oxide will then cross into the smooth muscle cell of the endothelial tissue and stimulate guanacylcyl triphosphate here, which will lead to a cyclical guanosine monophosphate, which then relaxes the blood vessel. We'll see the alternative route is by TNT or glycerol trinitrate, which is what they use for angina. You know, they put little tablets of TNT under the tongue there, which goes directly to produce nitrate, trinitrate, glycerol, to nitrite, to nitric oxide, to do the same thing to vasodilate the coronary vessels, which we'll see with angina. So that would be the pharmaceutical approach, and this might be our approach from a functional point of view, is we look at the level of acetylcholine. Do we have enough acetylcholine or do we not have enough? And the effect, therefore, on this nitric oxide synthase pathway. This may be the mechanism why such herbs like sage and lemon balm function in improving cerebral circulation. So we use lemon balm a lot for people who are beginning, and sage for people who are getting memory problems from vascular dementia. So the liver point is on liver 14 here, on the 6th interspace, on the left and the right, and the gallbladder is right on the lateral part of the orbit of the eye. Okay, so we're familiar with those from one of the other modules that we've done on neurotransmitters. So let's have a look now on noradrenaline, or norepinephrine as the Americans call it. So norepinephrine, noradrenaline is made from tyrosine, which goes on to produce L-dopa, to dopamine, and finally hydroxylated from dopamine into noradrenaline. And we're familiar, this first pathway here is involved with tetrabiopterin here to do the first hydroxylation process, and then decarboxylation of L-dopa to dopamine, and then dopamine is hydroxylated to noradrenaline. So noradrenaline itself, as we know, is a stimulant, isn't it? If we get an adrenaline surge, we want to get across the road fast, or we're under a lot of stress, our heart rate goes up. And our heart rate goes up to get more blood into the muscle tissue to get us across the road fast. So low levels of noradrenaline, which come off the small intestine 19 point here, or small intestine meridian, in other words, low levels will slow the heart rate, slower conduction rate, slower arterial contraction, okay, and slower ventricular contraction. So everything is slowed down. Okay, so with a low level of noradrenaline or adrenaline, you just get everything slowing down. So low adrenaline works on, or adrenaline works on the alpha receptors, and these are divided into 1 and 2, and the beta receptors. So we just have to remember that the receptor sites which pick up adrenaline and noradrenaline are divided into 2, alpha and beta receptors. So the alpha 2 receptors here is an inability to raise the blood pressure. So the alpha ones are mainly involved with constriction of the blood vessels, and the beta is an inability to increase the force and contraction of the heart itself. And the beta 2 receptor is an inability to release renin in the kidneys, which leads to hypotension. So noradrenaline, when it's high, has to therefore be broken down or metabolized, and it's broken down by monoamine oxidase to dihydroxymandelic acid, which is then methylated to vanillyl mandelic acid, which then goes on to be conjugated and excreted through the bile and the urine. So therefore, if we get a build-up of high noradrenaline because we're not metabolizing it, we'll then get increased heart rate. We get increased conduction rate, increased atrial contraction, increased ventricular contractibility. So we get into a hyper state. So you can imagine the blood pressure is going to go up, our heart rate's going to go up, and our contractions are going to go up. And the reason for this may be that we're simply not metabolizing or breaking noradrenaline down. So it could be just a nutritional deficiency. We're short on the methylating factors or the oxidizing factors or conjugating factors. So high noradrenaline is associated with the heart meridian. So that's a very apt one, really, isn't it? The heart meridian is associated with high noradrenaline. So the alpha receptors control the smooth muscle contraction. The alpha 2 receptors are the vasoconstriction. So this is the muscles, these are the vasoconstriction of the blood vessels. The beta 1 are found in the heart and increased force and contraction, so therefore leads to palpitations and tachycardia. And the beta 2 receptors cause the release of renin, which will then lead towards hypertension, in the kidneys. So now we can see that's how the common drugs, beta blockers, you've all heard of beta blockers work, is on these receptors that are found in the heart and increase the force and contraction, leading to palpitations and cardiac heart arrhythmias, which is why they always put these type of people on beta blockers, to calm them down. But of course it doesn't solve the problem. It solves the symptoms, the result of the problem, but it doesn't affect the what's actually the cause of the problem. So you have to find out, is it because we got high noradrenaline and we're simply not metabolizing it? We need the right nutrients to do that, or is it because we're eating certain foods which are creating an allergic type of response, which is stimulating an adrenaline reaction? So there's lots of reasons why we may get it. Here we see the angiotensin with renin converting to angiotensin 1 to 2 and 3. Now angiotensin 2 is a powerful vasoconstrictor and it stimulates aldosterone, which holds on, of course, to sodium. It's a mineralocorticoid in the adrenals. It'll then go on to angiotensin 3, which is a less powerful constrictor, and then gradually we get rid of it. So one of the ways to stop this powerful vasoconstrictor is to block the angiotensin converting enzyme, otherwise known as ACE. And this is where the drugs ACE inhibitors come from. So ACE inhibitors block this. But of course, it doesn't address the cause, but it can bring the blood pressure down. But the cause, whatever it is still going on. And this is the problem when people sometimes say that, my blood pressure is under control. But of course they've got all the factors that are causing the blood pressure, but it is artificially being controlled by a poison, a toxic substance, which is inhibiting an enzyme. So it's still much better to address. And you can muscle test these people, and they still test positive to the factors which are causing the problem. They may symptomatically, when you blow the blood pressure cuff up, be better, but it's not doing anything different to the fundamental cause. So angiotensin is made in the liver, as I said. Right, we don't need to go through that. So there's the stimulants there. So the points here, small intestine 19, just in front of the tragus of the ear and behind the head of the mandible. And the heart is right up in the top part of the axilla, just probably on the posterior part of the pectoral muscle there. So if you put the fingers right at the top of the axilla there, that's usually, you'll find it. Dopamine's interesting because dopamine you don't necessarily associate with blood pressure. So we've already covered dopamine by looking at noradrenaline, so tyrosine to L-dopa to dopamine. So low dopamine corresponds off on conception vessel 24. Dopamine receptors are mainly located in blood vessels and the heart and respond to exogenously applied dopamine, indicating their sensitivities. Heart Math Institute found that the heart actually secretes a number of hormones, oxytocin being one of those, and one of the most important ones otherwise is dopamine, the feel-good factor. So feel-good factors, when involved with the emotions and the heart and things, produce oxytocin and dopamine. So the heart itself secretes dopamine. So mesenteric and renal arteries can cause vasodilation. So here we see dopamine high levels being broken down the same as noradrenaline, monoamine, oxidase, methyltransferase, conjugation with sulfur, glutathione acetylation. So high dopamine comes off governor vessel 27, point here. Governor vessel 27 indicates dopamine receptors are mainly located, we said that. Let's go through there. So there's governor vessel 27 on the top lip. So bottom lip for low dopamine, top lip for high. So serotonin, conversion of tryptophan to serotonin via 5-hydroxytryptophan, exactly the same as dopamine pathways, hydroxylation with tetrahydrobiopterin, decarboxylation. So low levels of serotonin lead to low blood pressure. A bit as you'd imagine, you get the winter blues, the depression, you get low blood pressure with low serotonin. Also, as we know, you get low immunity because when you get low depressed brains, you get depressed low immune system functioning. So to get rid of high serotonin, same pathways, monoamine oxidase, methylation, conjugation. So high serotonin comes off the kidney 27 point. So often serotonin is called 5-HTP. So 5-HTP release either from the nerves or from the platelets causes vasoconstriction of all large blood vessels. So high levels of serotonin will lead to hypertension. So if the person cross-therapy localizes to kidney 27 from your diagnostic entry, your challenge, which could be your blood pressure or you're listening to the heart. But vasodilation, if you remember, the mid-meningeal artery, by gating incoming sensory inputs and by decreasing sympathetic nervous outflow. So remember, it's a vasoconstrictor on all blood vessels except the mid-meningeal artery, which is the one that leads to the migraine. So this is why the migraine headache is a vasodilation in the brain, but a vasoconstriction everywhere else. So if you eat certain foods which create high levels of serotonin, inflammatory chemicals in the gut, these float around in the body and they'll cause vasoconstriction, so you get like a hypertension, but then wham, you get the vasodilation, which allows toxins to permeate from the blood vessels into the brain and vice versa, and brings the migraine on. So high serotonin, high blood pressure. Low serotonin, bladder 1 in the corner of the eye, and kidney 27 onto the first intercostal space. Histamine, made from histidine, mediated by pyridoxal 5-phosphate to convert to histamine by decarboxylation. So low histamine leads towards low inducible nitric oxide synthase within the immune system, and this therefore may lead to high blood pressure. So ironically, low histamine may lead towards higher blood pressure. So we know histamine's on stomach 1 there. So histamine, when it builds up systemically, we have to break it down ultimately towards acetic acid here. And we know the most important compounds that break histamine down is vitamin C here, that stimulates the diamine oxidase enzyme, pyridoxal 5-phosphate. Of course, these are very important this time of the year, aren't they, because of the amount of pollens and allergies around with people. And also the aldehyde oxidase enzymes with molybdenum and B2 and B3 here. And remember, our real antihistamines that stabilize the cell membranes of the mast cells is vitamin E, zinc, magnesium, and the bioflavonoids. And the main one of that is hesperidin, sometimes quercetin, although it's not so water-soluble. But hesperidin is very, very important at this time of the year with people. Okay, so high histamine, which is spleen 21, we know high histamine occurs when we've got an infection, because we've got high histamine there, spleen 21. So therefore we got high inducible nitric oxide synthase to help activate the immune system to get rid of the bug with the immune system, and that may lead to low blood pressure. And that's when we feel prostrate and go to bed, because we've got this infection and all we want to do is just sleep because we've got no very low blood pressure. And you get up to go to the toilet and you feel dizzy and faint and things. That's because you've got low blood pressure because you've got an infection. So paradoxically, histamine activates cyclic AMP, which could increase blood pressure, but it's usually high inducible nitric oxide synthase. So histamine receptors outside of the central nervous system constrict large arteries and veins, relax the arterioles, which are the small arteries there, small veins and capillaries, especially in the brain, and increase permeability. So relaxation, histamine receptors outside, so relaxation of the arteries and especially in the brain itself. And I think this is why when you've got an allergy and you've got high histamine, you feel brain fog. You really can't think very well. And of course we're just coming up to the time of school exams now with mid-May and June. University exams, and if you've got a child who's doing these and they've got hay fever or pollen allergies and things, it's very difficult to think. You just get this brain fog, and you've really got to get them onto hesperidin. And remember, vitamin C helps to break histamine down, but the hesperidin, the vitamin E, magnesium, etc., are the true antihistamines that stabilize the mast cell membrane so they don't go ballistic and start producing so much histamine. So the 2-point stomach 1, which is on the inferior notch of the orbit there, and spleen 21, which is, if you bend the elbow here, is on the side there, the 9th interspace on the ribs. So bend the elbow at 90 degrees, and you'll find it exactly at that point. Okay. So that's a common point that we use treatment-wise as well. So the last two here, we've got GABA, which we know is an inhibitory neurotransmitter, comes off the large intestine and the lung. We've also got taurine and we've got glycine, but we'll concentrate on GABA just at the moment. So GABA is made from glutamate, which is an excitatory neurotransmitter, the next one we're going to deal with. And here we need a decarboxylation, so we need pyridoxal 5-phosphate here to take away the carbon dioxide to make GABA, which is an inhibitory neurotransmitter. And then interestingly, GABA transaminase, which is the enzyme that converts GABA down to succinic semialdehyde, is a P5P dependent enzyme as well. So we need B6 to make GABA and B6 to break it down. So if you're deficient in B6, or more importantly pyridoxal 5-phosphate, you may have problems and have high glutamate because you can't make GABA. So GABA slows us down, it's like the inhibitory neurotransmitter. Glutamate excites it. So if you've got a high level of glutamate, when you should be having, and you've got a low level of GABA, you may be P5P deficient. Okay, so hyperactivity in children or anybody who's hyperactive, the most common nutrient to look for is going to be what opens this pathway up, which is pyridoxal 5-phosphate or B6, magnesium and zinc. So the hyperactive child, all sorts of problems can be involved with low levels of GABA, you know, from more serious pathological, epilepsy, etc., fits because of low GABA. I'm finding a lot of Alzheimer's disease patients are showing to GABA, deficient in GABA, which is interesting because I haven't thought about GABA as involved particularly with the memory, but the research is early days, but it's interesting that GABA is the one that's primarily showing up to be out of balance with true Alzheimer's diseases. So GABA is an inhibitory neurotransmitter. It's not present in peripheral nerves. GABA-C receptor is where benzodiazepam, otherwise known as Valium, may relax a person's emotions and therefore reduce blood pressure. So the GABA-C receptor, if you stimulate that, it's like taking a dose of benzodiazepam or Valium, tranquilizer, and your blood pressure will go down. Okay, so it can reduce your blood pressure. So there's the 2 points, large intestine. Remember, if you follow the large intestine round, every book I've seen puts the large intestine point in a different position. And in earlier days, I realized that in graphics, to actually get a dot onto a picture, it could be here, 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 or there. It wasn't accurate in the early days of desktop publishing. But my finding is you follow around the crease of the nostril there to the nasal bone. Okay? So this part is the nasal cartilage. So you go around there and you just follow it to the end of the crease and you just feel it there. And it's usually slightly swollen with most people. And if you give it a good rub, it's quite tender in most people because most people got large intestine problems of some form or other. Okay. And sometimes it stimulates a sneeze when you rub it, but rub it hard. It's quite tender in a lot of cases, isn't it? Okay. If it's not tender, you're not on the point. Okay, so you have to sort of follow it around. So it's not actually on the bone; it's just on the nasal cartilage end of the bone. So large intestine 20 and lung 1 is just on the anterior part of the coracoid process here, the scapula. So it's in that little dip just under the clavicle. And finally, of the neurotransmitters, glutamic acid or glutamate, which is an excitatory neurotransmitter. This can be made from glutamine, and we're going to look at glutamine again a little later and its connection to diabetes. So glutamine converts by glutaminase to glutamate, the excitatory neurotransmitter, which can, of course, be transaminated, as we've seen, and changed back to GABA or into the amino acid pool to alpha-ketoglutarate to burn it in the Krebs cycle. And both those pathways need pyridoxal 5-phosphate and magnesium. So glutamate, high levels of glutamate can also be recycled back to glutamine here, but this needs ammonia to do this. Or it can be oxidized round here, which does tend to produce free radicals or for inflammatory byproducts. But the normal way of metabolizing high levels of glutamate is transamination there and burning it. So low levels of glutamate may indicate low levels of nitric oxide, as glutamate increases cyclical nitric oxide synthase, leading to an inability to lower raised blood pressures. So we know that triple warmer 23 here is the point. So low levels of glutamate, you know, as the effect may actually lead to hypertension because we don't stimulate enough nitric oxide synthase there. And high levels of glutamate are usually associated with the circulation sex meridian. This may indicate high nitric oxide as glutamate increases constituency of nitric oxide synthase, leading to lower blood pressure. However, both aspartate and glutamate, and there are agonists, there was aspartame and monosodium glutamate, may increase the heart rate. So these can have a detrimental effect on the heart rate, possibly either directly on the AV or SA nodes or through the vagus. They may increase heart rate and lead to tachycardia. So sometimes people, in fact, a very good example was Tony Blair. When he was Prime Minister, if you remember, several times he was rushed into hospital and then he had to have an ablation because he was in tachycardia. And this happened several times, and then on the final time he went in, and I remember Gary telling us the story because you were doing some film work with him, and he said, I'm not surprised, he's always in and out of Pizza Hut, eating junk food and Diet Coke. And of course he was getting high levels of aspartame, high levels of monosodium glutamate, and his heart was just going bum, 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 and then he had to have an ablation done. I think he was only about 50 at that time, and not exactly a very old man. So high levels, glutamate, can lead to low blood pressure, but can lead to, at the same time, tachycardia if in their synthetic forms. So the 2 points here, triple warmer 23, just really on the corner of the eye at about 10 or 11 o'clock. You know, right in there. You can just feel it again on the orbit round the corner of the eye. And circulation sex 1, which is about 2 centimetres superior to the nipple and 2 centimetres lateral in the fifth interspace of the ribs there, circulation sex. So nutrition's natural things to think about, perhaps bringing blood pressure down and getting it under control, are all obviously the cofactors to the specific neurotransmitter. So the best thing you can do is, if a person's got high blood pressure, is to have some marker diagnostically that they've got high blood pressure, which we may use a therapy localization point. We may use a blood pressure cuff if you can sustain the pressure. Some people use one hand over the heart and at thoracic 2 as a point. I still prefer, generally, the stethoscope is the easiest thing, with the stethoscope round, with the patient listening to their own heart there, the heartbeat, the subscapularis goes weak, and then you cross-check with the other hand the beginning and ending points and find which neurotransmitter it is that is the one responsible. So here we see taurine. This is an inhibitory neurotransmitter, slows things down. Adenosine, which we're just going to talk about. Magnesium, calcium, potassium, vitamin C. The oils, of course, omega-3, omega-6. Then we've got garlic here, cayenne pepper, hawthorn, hawthornberry, crataegus, and rutin, which improves the permeability of the blood vessels. So we're going to look at cayenne again a bit later. Emergency treatment for cardiac myofaction, infection, how to save yourself from having a heart attack, or if you've got a heart attack, how to dilate your blood vessels fast, is 2 or 3 capsules of cayenne pepper. Okay, so we'll come back to these. Adenosine, just to reiterate at this stage, is not a typical hormone or transmitter, but is probably the most important neuromodulator of the central and peripheral nervous system. It's a neuromodulator compound which has modulating effects on neuronal activity, increasing or decreasing the rate at which the nerve cell fires. Neuromodulators are distinct from neurotransmitters. A neuromodulator such as adenosine is more likely to be either constitutively released or released at times of high and low metabolic activity. Neuromodulators may act pre and post synaptically. There's at least 4 types of adenosine receptors. Adenosine receptors are typically thought to mediate stimulation or inhibition of cyclical AMP. Adenosine itself is used in the treatment of supraventricular tachycardia. So this is a standard hospital pharmaceutical treatment, but adenosine used to be known as vitamin B4. So it was considered to be an essential vitamin. So it had a number, which means you have to get it from your food, but it lost that status when it was realized that adenosine is actually made in the body to go on to make DNA, isn't it? It's a nucleotide base. So it basically lost its status there. But the richest source of this is nutritional yeast. So this is why, as we'll see, a nutritional yeast is put into various vitamin B compounds if you want to have the effect of vitamin B1 and 4, as we'll see, work together as what they used to call, Dr. Goddard used to call vitamin B complex. This is the main one which we'll see studies the electrical activity of the heart. So vitamin B1 or thiamine, vitamin B4 or adenosine, which is rich in nutritional yeast, are more vasoconstrictors, and they tend to stimulate and help modulate the excitability of the heart. So if it goes into tachycardia or arrhythmia, they usually give adenosine. But nutritional yeast contains the adenosine and is a good natural source.